Good morning. Hi. Oh my gosh, so it's your first day off orientation. That's so exciting. Okay, well, you're gonna do great. Our people, you have my people, right? Room 1 and 2? Okay, perfect. Yeah, they're not too bad. They're a little bit busy, but pretty stable, so you should have a good day. I think you'll be okay. Okay. You wanna get started? Okay. Oh, you're nauseous? Here, I think. Here, smell this. Old nurse's trick. Smelling an alcohol swab. I know. I get nauseous too when I'm tired, especially day shift when you wake up that early. I know. Okay. Is that a little better? Okay. Okay. So let's just get right into it. Our guy in room 1, super nice. You should have a good day, okay? John Doe, 57-year-old male, full code, allergies to penicillins, and that's an anaphylactic, so it's red flagged on the MAR. And then Epi is on there as well, but it causes him to get shaky. Whatever. History, we have hyperlipidemia, just a little hypertension as well. He takes metoprolol at home. He also has a history of AFib. He is a smoker, COPD, no oxygen at home, obstructive sleep apnea. He has some arthritis, and he takes Advil at home for that. He also has a history of an MI back in 2018, and he got 2 stents. One of them was in the LAD, and then I looked in the charting, and I don't know where the other stent was placed. So yeah, if you could ask, I don't know. He's a patient of Dr. Anderson from CV Surgery, and then Dr. Johns for ICU is following him as well. Basically, he came in yesterday, 5:26. He was having shortness of breath while mowing his lawn, and then he started having like really bad pain that was radiating to his shoulder. His wife brought him in, got an EKG. It showed ST elevation in the inferior leads, so 2, 3, and AVF. They loaded him up with aspirin. I think he got 325. I have to check the more though. I mean, they normally do, so. And then he didn't get nitro, obviously, because it was an inferior MI. Yeah, good job. Yeah, that's the only one you don't give the nitro for, right? Because those ones, you don't want to drop their preload. Yeah, yeah, yep, totally. Anyways, the STEMI was activated. Cath lab came in, brought him in to see if they could stent it. And when they went in there, they said that the anatomy of his RCA just showed like that it shared a wall with another artery. So if they were to stent it, it would block that artery. And his RCA was 100% occluded, but something happened in there. They couldn't stent it. So he did have to go in for an emergent cabbage last night with Dr. Anderson. It's just a cabbage ×1. They used the left SAF. He came back to us at about 8 o'clock. He was doing good. I'll just get right into it. Cardiac-wise, he is in normal sinus rhythm. 80s to 90s. He'll jump up there when you wake him up and stuff though, or if he's in pain, he'll get kind of tacky. He was having lots of PACs and PVCs, but I replaced his MEG, and his K is being replaced right now, and that's really helping the ectopy. So his MEG was 1.6, yeah, pretty low. So we did the 2-gram replacement, and then you'll recheck it at 10. And then the potassium, it was 3.8, so we're replacing 40 through the central right now, and then you'll just check that at 10 too. Yeah, you should be fine. Just per the protocol, yeah. Going on down. Blood pressures, he came back on dobutamine, but he started to get pretty tacky there at like 2 a.m. And he was just, I felt like he was going to go back into AFib, and I didn't want any arrhythmias. So I tried just kind of weaning it down. He did okay, but then he got kind of soft. So gave Dr. Anderson a call, and he wanted me to just start him on low-dose levo. So he's just on 3 mics per minute right now. You should be able to wean that off because I gave some albumin, and his CVP is good. His preload is fine. So I think he just needs a little extra squeeze for his heart to get back up to where it needs to be. So yeah, Dobuta's off, just the levo. He does have a swan. His hemodynamics look good. His cardiac index, it's pretty good. It's like 2.2. Yeah, and then his SVO2 is 70s, but it does drop down there to the 60s and 50s just when he wakes up and starts moving around and if he's in pain or whatever. CVP, when I lay him flat and actually get an actual reading with a good waveform, it's pretty good. It's around 10. Yeah, and it did improve like up to 12 and stuff after the fluid and the albumin. So that's good. And then SVR, he was like sitting around 800. So when I started the levo, obviously that got better. He's around 1100 right now. Looking good. Respiratory, got extubated at 2 a.m. without complications. He's on 5 liters just because he has so many secretions, and I've been trying to get him to cough it up, but he has that history of COPD and he just sounds pretty diminished. So I've really been encouraging IS, and then RT has been in there giving him his albuterol treatments, and that helps. So you could probably wean that down today as well. Sounds clear over dim, like I said. His x-ray this morning looked good. I don't know if he's ready to be diuresed yet. It does look a little fluffy, but with his hemodynamics, we just kind of want to be careful. We'll just see what the surgery says when they round. Yeah. Neuro, he's alert and oriented ×4. Really nice guy. I did talk to him about his history of smoking and how that has a effect on his heart, and so cardiac educator is going to be around today as well. He seems okay with it. He just seems a little kind of rattled with the whole situation, so I gave him some good just emotional support, and he's nice. He doesn't have any deficits. He moves all of his extremities. Pupils are equally round and reactive to light. His smile is symmetrical, all that good stuff. GI-wise, no BM obviously yet. I did advance to a clear diet. He swallows fine for me, so you can probably advance that as tolerated for him. He didn't have any nausea. There is Zofran on the MAR if he needs it, but just make sure you check his QTC because it's been fine for me, but I think in the chart it said that he had a history of just a little bit of a prolonged QT. I don't know why. Maybe he was on a certain med or something, but just keep an eye on it. Yeah, he's about 0.4 right now. Yeah, he doesn't have a bundle or anything. Totally just normal sinus. So, yeah, no ST elevation left. No, sometimes there's some residual there, but not for him. GU, he has a Foley that could probably come out once the levo gets weaned off, maybe 4 hours after that. Urine output was good, but when I turned the Dobuta down, it did drop, and that's one of the other reasons we started the levo. We didn't want his kidneys to take a hit. So it's been about 50 to 60 mils an hour, clear yellow, no sediment, no odor, nothing like that. His BUN and creatinine look good. Skin-wise, he has the midline incision that's covered with a dressing, clean, dry, and intact. He also has 2 chest tubes. The dressing on that I changed. They were just a little leaky. And he has 1 V-wire as well. But that's just capped and it's not even connected to the pacer. But if you need it, they're there. The chest tubes are connected to -20 on the atrium. There's no air leak or anything. Serosanguinous, they're wide into each other. So it's just 1 atrium. Yeah. And only 200 mils out for me. Yeah. He was good on that. And then he also has the left SAF site that's clean, dry, and intact. Other than that, he has a preventative Mepilex on. I'm trying to think if he has anything else. No, he's good. Activity, we did get him to the edge of the bed just to sit up. I was gonna try to get him to the chair, but I just didn't quite think he was ready yet. He was starting to get short of breath, and with his hemodynamics, his SVO2 started going down. So edge of the bed was good. We did some coughing, deep breathing. Pill's about $1,500 on the IS, so that's good. And then obviously we just got him back, and maybe today with PT he can get to the chair. They'll see him today. Yeah, PT and OT. Family wise, his wife Sandra did call, and I gave her an update last night, but she did want you to call her again, like maybe around 8, as she said that she'd like a call. So I'm just gonna leave her number right here for you. Just give her a call whenever. Yeah, she just wants an update. She seems really nice. Line wise, so he has a right IJ. It's not a Cordis, it's a Mac, and Swan's secured at 50. Yeah, and his PA pressures, they've been fine too. I mean, maybe a little bit elevated, 30s over about 15, but yeah. PA pressures have been good, CVP has been good. That's secured at 50, and then once the pressors are weaned off, you could probably get that out. Yeah. Right IJ, other than the Levo, we have D5LR at 30, and then a TKO at 10, just for our electrolytes. He's not on any antibiotics, but the potassium is just finishing running right now. I gave the magnesium first, because you know that, you want to give them magnesium before potassium, because it helps the potassium get absorbed better. You knew that, huh? Okay. Well, you're pretty good for it being your first day off orientation. You're going to do great. Pain-wise, I just gave him 10 of Oxy at around 5. I think that it might have been a little much. He's been a little bit lethargic. He was saying he was in 10 out of 10 pain, though, so maybe next time just 5. And then he'll get the scheduled Tylenol every 6 hours. Yeah, I think that'll help. Lab-wise, like I said, replacing the electrolytes, BUN and creatinine look good. Sodium was in with the normal limits. He doesn't have a history of diabetes, but he was on an insulin drip when he got back. Obviously, all of our patients are. But now that he's on kind of a clear diet, and he has a clear tray coming this morning, just turn that off, and his sugars have been within normal limits. So other than that, what other questions do you have on him? Yeah, I think he's progressing well. I think he'll do good. Okay. Yeah, and I'll be back tonight, so if you don't get to anything, like, don't even worry about it. Like, I'll do whatever. Okay. And then let me just grab my paper for our next patient. Ready for our next guy. He's fine. I mean, he's not as nice as the other one, but what do you do? I'm just gonna have something to eat quick. I feel like my blood sugar's low. Want one? You good? Okay. I know. I love Sour Patch Kids. I love the blue ones. I know. They're my guilty pleasure, like 4 a.m. I know. So bad. Okay. A piece of gum. Here you go. Okay. So, we have Mr. Troy Bolton in room 2. He's a 70-year-old male. History-wise, he has been admitted a couple times for pneumonia. He also has a history of COPD, smoker. He also has stage 3 chronic kidney disease. Baseline creatinine is about 2. Right. Yeah, we got to be careful with that. Yeah, those nephrotoxic meds, yeah, you got to be careful. Anyway, he also has a history of diabetes, type 2. He does have a couple admissions in addition to the pneumonia. where he goes into HHS. Yeah. I think he might have some issues getting his insulin. I don't know if he's homeless, but he does say that he kind of switches up his story a little bit sometimes. I know he lives with his mom, but that, he doesn't really have like a stable place, and I think that affects his ability to get his insulin. So I did get a social work consult on him, see if we could help him with that. Basically, yesterday he came in, he was feeling just like hot and dry and just not feeling like himself. Right, hot and dry, sugar high. Yep, you got it. Yep. Checked his blood sugar, he was like 800. Yeah, poor guy. So they started him on the 2-bag system, and he's doing better. He should downgrade today because he got weaned off the 2-bag system. His gap closed. I know they don't really use the gap with HHS, but all of his electrolytes normalized and things like that. So we gave him his Lantus at like 6, and then they want us to just turn off the bag at 8. So you're going to turn it off and then just check it before he eats breakfast, and he'll be on a carb-controlled diet, and then just start giving him his Novolog. Yeah, we got him down to like 120s. It did take all night though. Yeah. We obviously didn't want to do it too fast, but yeah, 2-bag system. I know you haven't used it yet, but you're gonna turn it off at 8. It's already 7:30. Like, we could just go in there and turn it off. Just when we go say hi to him, let's just do that. That way you won't have to worry about it. Okay. Full code. Allergies to sulfas and latex. So we have some latex-free gloves in there. Patient of ICU. Yeah, same doctor as last time, Dr. Johns. I already told you his history. Came in with HHS. Cardiac. He is in like a rate-controlled AFib. I think he has a history of that too. Yeah, he takes Eliquis at home. Yeah, but I don't know how well he's been taking his meds, so we'll have to stay up on that. He is going to get it this morning, his Eliquis. Yep. Pressures have been normal. 120s over 70s was the last one. Yep. Respiratory, room air. Yep. He's been good like that. Clear over dim. He does have a strong cough, and he has been coughing some stuff up, so I'm just encouraging him to kind of suction it out. He has his own yonker in there. And I've been doing good oral care because he doesn't have the best dentition. Yeah. Yep. Going on down. Neuro. Alert and oriented ×4. He is a little ornery. He doesn't like you to go in and bug him. So when I was going in to check his sugars, he was getting mad at me, but he's easily redirectable. I mean, yeah, he's not agitated or anything like that. I think he's just kind of needs some emotional support. GI, no bowel movement, but he will start on the carb-controlled diet here at 8. I already ordered it for him, so we're just waiting on the tray. Yeah, exactly. So hopefully the tray will come when we go in there. Give him the tray, turn off the 2-bag, check his sugar, and give him his Novolog. He's on medium dose sliding scale. Yeah. No carb coverage, but hopefully that'll cover him, and then just monitor it at least every 4 hours, and then he should go to the floor, if not even home. But I do think that social work does need to come see him first. Just make sure that he has a good stable home where that he's safe at, and that he can get his meds, that he has a ride to get his meds or whatever. I tried talking to him about it, but he just seemed like he wanted to sleep, so GU, he's been good. Peeing in the urinal. Like 800 out for me. Skin-wise, he does have some ecchymosis and redness, and his epidermis is pretty thin. His toenails are kind of long. Yeah, I don't know if he sees a podiatrist for that, but I put some of that cream on there on his legs because they're kind of scaly. Yeah, I don't know. He looks kind of unkept. So maybe he can get a good bath today. He didn't want one for me. He wanted to sleep, so. Activity. He gets up just times 1 assist. Yeah, he can get up. He doesn't have any family that I'm aware of that has been calling. There's nobody on the MAR as a point of contact, so maybe we could talk to him about that today. Yeah. Line wise, he has a left AC 18 gauge. Yeah, ER got it good. I mean, he was pretty dry and a hard stick, so that's one thing they're good for. Of course it's in the AC, I know, but what are you gonna expect? I know. He also has a 22 in the right hand. It works well, but I would definitely use the 18. Yeah. Lab had a hard time drawing him at first, but now that he's rehydrated and not in HHS anymore, they're having an easier time. Morning labs. So like I said, creatinine's back to around 2. BUN looks okay. Glucose has been about 120. And then sodium's fine. Yeah. Mag was a little low, 1.8. So we're replacing that right now as well. Yeah. And then K was fine actually, which is weird because no, it wasn't. Yeah, that's exactly what I did. We rechecked labs at 1 a.m. and I replaced 40 PO, and then now he's back to 4.2. But as you know, when insulin and fluid go back into the cell, it takes potassium with it, and so you can have shifts in your potassium. Yeah. So labs are going to be redrawn at 8, but you won't have to do that because Fleb will do it because he doesn't have a central line or an art line, but our other guy, you will. Right. Other than that, any questions on him? Yeah, I know. Right. Yeah, you can talk to him for sure. Seems like a nice guy. He's a veteran. And he gets his care at the VA as well. So I don't know if it's something with the VA where he can't get his insulin, or maybe he doesn't understand it well enough. But the diabetes educator will be in as well. I already messaged her. Yeah, she's really nice. And she'll talk to him too. But I'll be back tonight. I know our guy over here might be discharged or downgraded. Our other guy shouldn't yet since he's still on pressors. But yeah, I hope you have a good day. And do you want some flushes? Use these. Yeah, just keep them on you. Yeah, well, you should have a good day. Just ask the charge if you have any questions. Main thing is always your drips, making sure your drips don't run out, but the only presser we have is our guy in 1, which is the little Levo. It's not like he's on 5 pressers or something. Yeah, just, look at your labs in the morning, look in your orders, look at the latest doctor's note, look through your MAR, see what you have continuous PRN, make sure I didn't miss anything, and then just kind of go in there, assess your patients head to toe. But you're always assessing your patients, right? You don't have to just do it in the morning. Yeah, everything's an assessment, and most of the time it's just that cross the room assessment, if their eyes are open, if they're talking, if there's color in their face, all that stuff. So yeah, just have that attention to detail, and if you have any questions, just always ask is the main thing. Yeah, exactly. You're not going to be perfect. If the doctors are rude to you, just shake it off. They're always rude, especially to the new grads. It's so stupid. I know. Don't let them get to you. It's okay. Yeah, the nurse practitioners are really nice. Yeah, I love her. Okay, well, you have a good day. Let's go say hi to them, update our whiteboards, and then I'm going to head out. Okay. All right, girly. Let's go. Guys, okay. My name's Hannah. I am doing this YouTube video for literally my own purpose of going to bed at night, because I get ASMR so crazy. Like, the best ASMR in the mornings when I get report from night shift, because I'm a nurse for some reason. So I'm just gonna try to replicate that just for fun. I don't know, I feel like I need to do it. Yeah, and we'll just see what happens. I'll throw it on YouTube, but it's only for me, so. But if somebody else wants to listen to it, it's just for sleep. Obviously, all the patients, like, are just completely made up, and it's totally fake, so hope you like it.